Welcome to the third day of pre-licensing training. I am Shannon Drake Burr with Covering Wisconsin. This morning, we welcome our two presenters from the Office of the Commissioner of Insurance back, Julie Walsh and Shelley Knorr. We are going to start this morning with Health Insurance 101. Please note that this morning we will be going a bit longer than we have on previous days. So we're starting at 9, we're ending at 12:15. We will have breaks at approximately 10 o'clock and 11 o'clock. And then we will conclude pre-licensing training. So with no further ado, I will hand things off to Julie.
Good morning. I assume you can hear me right now?
We can hear you.
Great. So as we spoke yesterday, the OCI's mission is to protect and educate Wisconsin consumers by maintaining and promoting a strong insurance industry. We do that through our regulation, making sure that we have an even playing field for all participants, not only the insurers, but also the consumers. And we also balance, as a state regulatory agency, the legislature. Next slide, please. So I wanted to quickly give you a snapshot of how we got to health insurance. It's not nearly as old as property and casualty or even life insurance. Some of those started in OCI was created in 1870, but health insurance really didn't evolve until the beginning of the 1900s. In approximately 1929, 1930 range, large industrial employers were finding that it was save their employees time if they had arrangements for healthcare for those employees. And so they started some kind of arrangements, kind of like the direct primary care you might see today, that brought in some care. And then in the 50s and 60s, with the rise of labor unions and individuals coming back from multiple different incursions that the United States was involved in, there were more people seeking health insurance to help defray some costs. And that really was creating a safety net for catastrophic health conditions. Just for a comparative, my parents' insurance was always the traditional 80/20, and they got like a $50 credit when I was born because it really wasn't intended to be first dollar coverage. In approximately 1965, Medicare was passed, and it was very revolutionary at the time. And it took a long time for Medicare to get in its place in the country as an accepted process for health insurance for our seniors. And it was primarily for our seniors, and then also included the disabled and blind, as you heard yesterday, and it's growing. But it took a while to get its roots set initially, and there was some pushback with it. Then in the 1970s started evolving the concept of this managed care. It again was with either large employers or large health systems that kind of thought that we could do this better than this 80/20 process. And they took on more risk in exchange for limiting who people could see. So I wanted to just give you a backdrop that this is still in its infancy compared to some of the other lines of insurance. Next slide, please. So just as we spoke yesterday, I'm just briefly touching on the basic principles of what insurance is. It starts with a risk. And for health insurance, it's the risk and your financial risk of what happens if you get ill. Who's going to take care of you? How is it going to get paid for? And obviously, healthcare expenses have grown exponentially in the U.S. And you get into the relationship by when you transfer your risk. My fear or concern about financial risk if I got ill to an insurance company, for them to bear that risk, for them to pay my expenses at our agreed levels, in exchange for me paying a premium. And the balance that has to be struck for all the people that you'll be working with is finding that sweet spot of how much risk they're willing to tolerate versus how much premium and other cost sharing they can afford. So I am incredibly risk adverse. If I could, I would have, the most platinum level plan you could think of. But like everyone else, I'm on a budget. So I can't afford, that Cadillac coverage that used to kind of exist and is harder to get today. Um, I carry earthquake insurance. I mean, I really don't like having that unknown be on me, but it's balanced against what we can afford. So, part of today, in both this first hour and in the second hour, we're going to walk through with all of you how to make and help the consumer you might be working with make these decisions on where is that sweet spot for the consumer. One of the things that they're going to see, and the reason that there's differences in both coverage options and premium between group products and individual products, is this concept of pooling. So if you're able to offset a single person's risk, there's not anybody to build it off of, right? So my premium has to be sufficient to cover what the insurer believes are going to be my health risks. If I am one of 100, then those numbers change, and it actually lowers the single risk by spreading it across the pool of the employees or in that group. So that's why you might see group health insurance premiums being lower than an individual's premium, because the insurer is able to spread the risk among the pool. So in the United States right now, and it probably won't be surprising, is that healthcare right now, the group that is least covered is actually the group running between 18 to 24, are about 29% of the uninsured population. 1 in 7 children under 17 are uninsured. So part of what we're hoping, and you've heard these in different statistics with the ACA, the opportunity that you all will have is to try to find affordable coverage for these populations who tend to shy away from, for many reasons, being fully insured. And there are lots of reasons why people may or may not be insured. Next slide. So health insurance is a really big term, and you'll see in the statutes when you're studying for your exam that health insurance is actually under the header of disability. It's disability, accident, and health. It's a big pool um, of care, and how insurance defines this are the bullet points that you see on your screen. That it is going to involve claims and covering medical and surgical expenses. It indemnities for loss of income due to an accident or a health incident, accidental death and disability, hospital care, and long-term care. So all these are categories that would be considered within disability insurance. So you will see distinctions, and Shelley will be going through some of those, where we start refining the words we use to narrow down what parts of health insurance are being affected by the product that you're looking at. So when ACA is really dealing with comprehensive medical services that are going to cover medical, surgical, hospital care, and may have some home health or some nursing home care, because it's the continuum of coverage that needs to be met in a comprehensive health insurance policy. I'm going to switch over to Shelley. And next slide, please.
Good morning. So the commissioner's role with health insurance policies varies, but here's some definitions of things that we can have a role in on a day-to-day basis. One of the things that we can do is have jurisdiction maybe when a policy is purchased in another state, but there are some caveats to that. First of all, insurance law follows the state where the policy was purchased in. So for example, when an employer is located, let's say in the state of Missouri, but has employees here in Wisconsin, there can be times when OCI could have jurisdiction over the health insurance plan for those folks located here. The rule would be that there needs to be at least 25% of the total number of employees residing in Wisconsin in order for us to have that jurisdiction. Most disability policies offer a wide range of coverages and limits. The commissioner has the authority to regulate the terms of the insurance contract to protect the policyholder. The insurance laws establish statutory standards explicit enough to protect the insured and to give the commissioner the authority to set specific standards and provisions throughout the rulemaking process. A group insurance policy is defined as a health benefit plan that is issued by an insurer or through an employer on behalf of a group consisting of at least 2 employees or a group including at least 2 eligible employees. The term includes individual health benefit plans covering eligible employees when 3 or more are sold or through an employer. A group insurance plan is defined as an employee welfare plan. This is defined in Section 3, subsection 1 of the Federal Employee Retirement Income Security Act of 1974. To the extent that the employee welfare plan provides medical care, including items and services paid for as medical care to employees or their dependents. And a defined network plan is defined as a health benefit plan that requires an enrollee of the health benefit plan or creates incentives, including financial incentives, for an enrollee of the health benefit plan to use providers that are managed, owned, under contract with, or employed by the insurer offering the health benefit plan. Next slide, please. Healthcare plans mean an insurance contract providing coverage of healthcare expenses. Health benefit plan definitions identify coverages that are not covered under this term. A comprehensive health insurance policy offers extensive coverage and acts as a financial pillow in case of medical emergencies. Unlike basic health insurance plans, a comprehensive policy covers outpatient as well as inpatient treatments, including consultations, medical tests, as well as hospital stays. Disease-specific policies provide coverage and benefits only for causes of sickness, disease, or injury, such as heart attack or stroke, and coverage is often in limited amounts or limited to a specific amount of time. Next slide, please. The larger the group pooled together, the greater ability to spread the risk. Individual policy only one person versus a large group in policy employs 10,000 employees, the insurer is able to spread its risk for high claims by collecting premium for more people, which then reduces the insurer's risk and typically then lowers the premium. Health insurance provided to employees by an employer is called group coverage, but health insurance you purchase not through an employer or association is called then individual coverage. In a self-funded health insurance plan, the employer assumes the risk for the employee's healthcare claims under the terms of the plan, and the insurance company then acts as a third-party administrator for the processing of those claims. OCI does not have jurisdiction in most disputes regarding these types of plans. We would then have to refer the consumer to the U.S. Department of Labor for assistance. Large group is defined as 51 or more employees. A small group is defined then as at least having 2 and up to 50 employees. The Small Business Health Options Program, or SHOP, marketplace plan helps small businesses to provide health coverage to their employees and is open to employers with 50 or fewer full-time equivalent employees. The 80-20 part of health insurance refers to co-insurance. Your health insurance pays for 80% of the total cost of the bill. Most co-insurance plans do cap the amount you pay with out-of-pocket limits. You would pay 20% of your total healthcare costs until you reach that out-of-pocket limit. Managed care plans are a type of health insurance. They have contracts with providers and medical facilities to provide care for members at reduced costs. These providers make up the plan's network. For example, an HMO usually only pays for care within the network. Some examples of federal programs are Medicare or Medicaid, and some state example programs are Badger Care and Care for Kids. Next slide, please. A managed care plan is defined as any health benefit plan that requires or creates incentives for an enrollee to use providers that are owned, managed, or under contract with the insurer offering the health benefit plan. Wisconsin statutes define 3 different types of managed care plans. They are health maintenance organizations, preferred provider plans, and limited service health organizations. A defined network plan is a health benefit plan that requires an enrollee. No, excuse me, that's a duplicate sentence. So we can go ahead to the next slide, please. So some of the distinctions regarding managed care plans is when a consumer selects a plan with less choices for a network, the premium will be lower versus selecting a plan with more choices, which in turn means more premium. Next slide, please. HMOs, or health maintenance organizations, offer predictable cost sharing and administrative simplicity for their patients. These features come with fairly restrictive rules about which provider patients may see. LSHOs, or limited service health organizations, offer a limited range of services performed by providers selected by the organization. A preferred provider plan, or PPO, plans select more flexibility when picking a doctor or hospital. They also feature a network of providers, but there are fewer restrictions on seeing non-network providers. In addition, your PPO insurance will pay if you see a non-network provider, although it may be at a lower rate. A point of service plan, or POS, is like an HMO. It requires the policyholder to choose an in-network primary care doctor and to get referrals from that doctor if they want to see a specialist. Next slide, please. So this is a purely descriptive slide that shows, again, when a consumer chooses a plan with less choices for a network, the premium will be lower versus choosing a plan with more choices, which in turn will then mean more premium. Next slide, please. Another way insurers protect against risk is to narrow the coverage options they offer, this time through the type of care or treatment they will cover rather than at the provider level. These are some of the examples of those types of plans. Accident only, blanket accident or sickness, critical illness, cancer only, HIV indemnity, intensive care, hospital indemnity, and sickness only. Next slide, please. Qualified health plans are comprehensive and ACA compliant plans offered on and off the federal exchange. Medicare supplement policies provide coverage for some of the costs not covered by Medicare Part A and Part B, as we previously touched on yesterday. Medicare Advantage is a federal plan using limited service areas, and it replaces traditional Part A and Part B. Medicare D is the federal program that offers the outpatient prescription drug cost. We'll get into some slides here in a little bit regarding long-term care and short-term duration policies as well. Next slide, please. So limited duration short-term plans are a type of health insurance coverage that was originally designed to fill temporary gaps in coverage that occur when a person transitions from one plan to another. Short-term plans can and typically do exclude coverage for pre-existing conditions. An insurer can review the consumer's medical history after a claim has been submitted to determine if there were prior symptoms that would have caused a reasonably prudent person to seek treatment and to use that as a basis to deny a claim. This is called post-claims underwriting. Many plans also state that conditions that develop under the prior plan, if the policy was renewed, will be considered pre-existing. Please understand that these types of plans may not have an offer to renew. There is no guarantee that they could be renewed. Next slide, please. And again, we touched on a little bit yesterday about healthcare sharing ministries. There are over 100 of these certified by the Federal Department of Health and Human Services as meeting the minimum requirements to meet the individual mandate under the ACA. The member is required to pay any medical bills first, with certain health needs eligible to be posted in a newsletter or for other members to help donate funds to offset these expenses. These were the original GoFundMe types of accounts. Next slide, please. So some of these, again, yesterday we touched on, but self-funded ERISA plans are typically for larger employers and governed by the U.S. Department of Labor, as well as the labor union and employee welfare plans. Medicare Advantage plans are the federal government's version of the Medicare EPO, and it again replaces Medicare Part A and Part B. The Centers for Medicare and Medicaid Services directly contract with insurers to provide these Medicare benefits. While we don't have jurisdiction over these types of plans, we do over the sale of them or the agents involved in them. Medicare Part D is the outpatient prescription medication. Next slide, please. So again, some of these we touched on yesterday. Medicare is the federal program that provides the assistance to help anybody, usually over the age 65, with their healthcare cost. ERISA helps establish the voluntary retirement and health plans in a private industry to protect individuals in these plans. COBRA offers the continuation of benefits when a person loses their group health coverage, whether it's between losing a job, reduction in hours, divorce, death, those types of life qualifying events. HIPAA is the assured health insurance portability by eliminating the job lock due to pre-existing medical conditions. It reduces healthcare fraud and abuse. It enforces standards for health insurance and guaranteed security and privacy of health information. The mental health parity prohibits group plans that offer mental health benefits from imposing more restrictive annual or lifetime limits on spending for mental illness that are imposed on the coverage of physical illnesses. And the patient protection, or the ACA, is to ensure that all Americans have the access to these qualifying health plans without the pre-existing conditions. Next slide, please. The ACA was enacted in March 2010 and was the most significant health change to health insurance since Medicare was enacted in 1965. It addresses the quality of care, the cost of care, accessibility, and gaps in insurance coverage. Some of the health insurance reforms began in 2010, and some of them did not begin until 2014. Examples of the reforms include prohibiting lifetime dollar limits and annual dollar limits on essential health benefits. The ACA provided for the 2014 implementation of health insurance exchanges, also called health insurance marketplaces, a federal website that allows consumers to purchase these qualified health plans and determine their eligibility for federal premium tax credits and cost-sharing subsidies. OCI continues to have regulatory authority over the insurance companies that offer coverage through ACA here in Wisconsin. However, we do not have any authority over the marketplace themselves since they are a federal entity. Next slide, please. There is on our website an interactive map that will break down county by county which insurers offer coverage in that area. This also provides the plan type and whether it is marketed through the marketplace. No consumer who signs up for coverage can be refused or have coverage limitations placed on them, such as a pre-existing condition on an ACA policy. There are 10 minimum essential health benefits required to be covered by the ACA. They are ambulatory patient services, emergency services, hospitalization, pregnancy, maternity, and newborn care, mental health and substance use disorder services, prescription drugs, rehabilitative and habilitative services and devices, laboratory services, preventive and wellness services and chronic disease management, and pediatric services, including oral and vision care. For 2022, the amount listed in the slides are the most an individual or family will have to pay out of their pockets for covered expenses. Next slide, please. Under the healthcare law, insurance companies can account for only 5 items when setting premiums, and those are listed in the slide. However, states can limit how much these factors affect those premiums. The ACA provides that comprehensive, individual, and small group coverage plans be categorized into one of 4 different metal tiers. The tiers represent the average portion of expected costs a plan will cover for average populations. These percentages the percentages the plan will spend on average are 60% for bronze, 70% for silver, 80% for gold, and 90% for platinum. There is also a catastrophic health plan through the ACA available to eligible individuals who are under the age of 30 or who qualify for hardship exemption. Bronze plans usually have the lowest monthly premiums, but the highest cost out of our pocket when one gets care. This plan is often selected if one usually uses few medical services and wants protection from very high costs if they were to get sick or injured. The platinum metal tier usually has the highest monthly premium, but the lowest cost when receiving care. And I'll turn it back over to Julie.
And the next slide, please. So we're getting ready for open enrollment. The 2022 period starts November 1 and will go through December 15th at this time. Open enrollment, as you know, is the time when all consumers can elect new plans, see what else is in the marketplace, figure out if they want to stay on the same metal level. There is some assurances that have been given that some of the additional supports that came through the federal act that passed in March that help lower premiums for people, especially who are in the lower income brackets, to gain additional advanced premium tax credits, which lowers the premium, might also still remain in place in 2022. If you enroll someone during the November 1 to December 15th time period, as long as they pay their first month's premium by December 15th, those plans then become available on January 1 of 2022. So we're always slightly ahead. Outside the enrollment period, this open window, there are limited times where consumers can traditionally get back into this marketplace. Obviously, if you remember this past year, President Biden did allow unique special enrollment opportunities for almost any reason during the period of March through end of August. So next slide, please. So these special enrollment periods, or SEPs, are available typically only when certain qualifying events occur. A loss of coverage through loss of employment or divorce or separation, a change of residence, and not just across the street, but leaving your zip code or leaving your community, leaving a county, leaving the state, because that may affect whether or not your plan still covers you. Being no longer eligible for Medicaid, newly obtained citizenship, or a life event, a birth of a child, marriage, adoption of a child, or placement of a foster care child. These events, and with experience on the ACA, allow these consumers an opportunity to relook at their health insurance for a limited window, typically 60 days from the event, to decide whether or not they want to go on to the exchange. Adding a dependent may change the advanced premium tax credits. So if there's anything that happens during their time while they're on the marketplace, it's important to update or go into and evaluate whether or not this is the right option for them. The other thing that can happen is students. So right now, as you may be aware, dependents actually don't end at 18, but go up to age 26. And when a student or a dependent, an adult dependent loses coverage by aging out, they also get an SEP opportunity. So the next slide should be a polling question for you. And it is special enrollment periods allow individuals to enroll in the ACA outside the normal enrollment period when a person when that person, A, decides a different plan would be more cost effective, when they receive a promotion at work, when they lose eligibility for Medicaid, or when there is a diagnosis with a severe illness. Michael will give some people some time on that. There we go. Great. Good job, everybody. You're correct. C is indeed the correct answer. So while you may find a need for health insurance when you have a diagnosis of severe illness, you're going to need to be sure that you get a comprehensive plan that cannot pre-X that. But it changes in your wanting a more cost-effective plan outside of an open enrollment period or a special event, you cannot do that. You can, if you receive a promotion at work, it doesn't really change your eligibility for health insurance. So C, losing eligibility for Medicaid is the correct answer. Next slide, please.
We do have one question I'd
good.
like to address, Julie.
Great.
So the question is, do people need to file taxes to apply and to qualify for any of the qualified health plans? And I can go ahead.
Go ahead, Shannon.
I was just going to share that. So if somebody is doing a marketplace application, it's more if you actually enrolled in marketplace coverage, then the following year, you'll have to do your taxes for the year. Now, if you were previously enrolled in a marketplace plan and you didn't do your taxes at the end of the year, there may be specific consequences related to that will come up when you're attempting to re-enroll or sign up for a new plan. But it's not so much that you need to have done your taxes in order to apply and qualify, but that you need to do them in response to having had that coverage, that marketplace coverage. Anything to add, Julie?
Yeah, so the reason for doing that, if you elected to have advanced premium tax credits applied immediately to your premium to reduce your premium, which is what most people do, the filing of your taxes allows the truing up of whether or not the amount that the government gave in an advance credit matched up with where your income ended. So one of the things when you're applying is you have to project what you think in your best mind at the time that your income is going to be. That gets trued up when you file your taxes. So if you guessed that your income was going to be 20,000 and it ended up being 40,000, you may have received more assistance than you were actually entitled for. So one of the things to do in addition to filing those taxes is also that if you're advising any consumers is to let them know that if something happens, they get a new job, they get a promotion, their partner has income and that increases their own income somehow for them, that they need to update their application. So if you've changed jobs and you're now earning the 40,000, although it was accurate when you applied at 20,000, be sure you go into the marketplace account and update your income. It will change those advanced premium tax credits, and that's why they look for that tax form in the subsequent years that you're on the marketplace to make sure that that got trued up. You can indeed apply without having done that, but there will be a window in the beginning of, in this case, 2022, where the insurer that you elected is going to be receiving information from the feds in an electronic transaction. And one of the flags will be that you had not filed your tax forms. So they'll be looking for that. and asking you or the consumer in order to make sure that that trues up the amount of income and the amount of advanced premium tax credits.
And I think we should further note this is true for consumers who may not be used to filing taxes because of how low their income is. So if you're signing up for somebody who's unfamiliar with filing taxes because they've had very low income and they're getting marketplace coverage for the first time, this is an important thing to discuss with them, that they will need to file their taxes, and then connecting them to help to file those taxes. There are resources in Wisconsin and across the nation to help people file for taxes so they don't have to feel like, oh goodness, I got help getting health insurance and now I have to also do taxes, but I don't know how to do that. There's help for that, and we'll post a link to that in the chat. We do have another question, Julie.
Great.
So the question is, did I hear correctly that premiums have to be paid by December 15th for January 1st ACA coverage?
You did hear that. There is a grace period that would go into place as well, but the government really would like to see that payment so that coverage starts on January 1. What will happen if you don't pay by December 15th for the January 1 coverage would be the insurer in the first 30 days will be processing those, but will be then on a retrospective basis applying your premiums so you can get behind quickly in the premium payments. So you should have your premium paid by December 15th. The feds have made some adjustments with that over the years of the ACA, and there is always the grace period opportunity. But it's a pretty narrow one if you're not getting advanced premium tax credits. It's 10 days typically because it's a monthly premium. Shannon, do you have anything to add to that?
I do not. And it looks like we've gotten through all the questions, so we
Great.
can go ahead and proceed.
All right. So the screen, the slide that's up in front of you is prepping you for open enrollment period. So mid to late October, the Shelley referred to the OCI's website is going to have a map of the state of Wisconsin that will show you which plans, which insurers are operating in each of the counties of the state, in our state for the 2022 plan year on exchange. Plans that have on exchange products have to also have that same product or a substantially similar product off exchange. Occasionally, for consumers who are not advanced premium tax credit eligible, so they have higher income, occasionally they will find a better premium off the exchange than on the exchange. They're typically the differences that I've heard about from insurers are usually added benefits that they can do within that substantially similar product off exchange. So sometimes it's more economical to, when you're not getting any assistance on the exchange, to look off the exchange. For exchange plans, the good news for Wisconsin is all counties are covered. Some insurers are actually expanding their coverage areas for 2022, and you'll be able to see that in just a few short weeks. That page is, the website link is on the slide, and it will, right now it will show you for 2021. It will be updated, and there is at least 2 plan options, I believe, in every county for 2022. So insurers are feeling a little more comfortable. Part of that is the reinsurance program that the state is funding to help offset some of the big costs that insurers are receiving. But this interactive website, actually, you can narrow down into a county and it will highlight not only the insurers, but the products that they're offering. How many are they doing in bronze and silver, gold and platinum, and give you the range. So that will be coming, but it looks like, again, 14 insurers will be on exchange for 2022. The next slide, please. So now we're going backwards a little bit, again, back into our basic concepts of health insurance. And in this, Shelley spoke briefly yesterday about interest on claims. So one of the things that we wanted to talk a little bit deeper about is, what does it mean to have a claim perfected? So the insurers are looking for sufficient documentation to make a determination of liability. So that's true not just in health, but in all lines. But for health, what they're looking for typically is, the date of the service, what was done, who that was the provider, where was this service actually provided? Was it in an office? Was it in an outpatient clinic or a hospital setting? The reason for looking at that type of information is there may be coverage, but first, is there coverage for that procedure? Two, is that a provider who's permitted to do that procedure? Three, is this a location where that procedure is supposed to happen? So was something done in an office space that's really supposed to have been done in an outpatient clinic? Or more likely, that something was done in an outpatient clinic that really could have been done in an office. And so in the contract that the insurer has with providers, all of those types of pieces are addressed in their contract and sets up their reimbursement. So when they're not following the rules that they agreed to, there may be a mismatch. And so the insurer is trying to determine what they have to pay versus maybe it's, maybe you got an additional service that's actually not covered, or it was covered in the wrong place. Those types of errors typically fall on the provider, not on the consumer. So it's not something that the consumer is going to get hit with, but there could be delays that do not trip interest on that claim, because they're still trying to perfect that claim. So interest actually doesn't start until overdue payments are at will be getting interest of 7.5% a year. And that's from the date that they have all their information, not the date that you submitted it or it was submitted for you. So in that time, so those are the delays that you can't necessarily anticipate. But when those happen, depending on how you have your, whether or not you've assigned the payment directly to your provider, or if the money is going to come to you and then you pay your provider, is where that interest is going to fall. But once they have all those facts, they do need to process those claims timely. And that is true for a lot of the providers, but not for like Medicaid or self-funded plans that aren't paying this interest, and Med Advantage. Again, those are, Medicaid is a duly funded state and federal money. Medicare Advantage, like the base Medicare, is a federal program as well, and self-funded is the employer typically that is funding that. And the interest isn't unusually would not be paid to a provider. So in a provider agreement, they're really saying for X number or this type of care, we're going to compensate you this amount of money. If there are delays, and the most frequent thing that happens with providers is a miscoding. So they meant to type in, a simple office visit and it got coded as a complex office visit. There's going to be reviews by the insurer. So again, that's going to cause a delay, but it's not going to trip interest. Next slide. So you all have heard a lot about, and I'm sure, pre-existing conditions. So what that is, as Shelley identified before, it's something that a prudent person should have or did seek coverage, care for. So you played soccer and you got your knee whacked out. A prudent person would probably get that looked at. So if you claim that on a new application for insurance in a short-term limited duration product, that your knee is fine, you didn't identify that as having a problem, and you end up needing to go to the doctor, they're going to do that retrospective review underwriting, and they're going to see that you injured your knee because the injury date predated your insurance policy, and that's going to be pre-X'd out. So there's going to be no coverage for that. The big difference for short-term limited duration policies versus ACA compliant or qualified health plans is pre-X is a big one. The ACA plans cannot exclude pre-existing conditions. That's why on the slide earlier on the polling question, I don't think it was a reasonable answer to say that you got a severe illness. When there's a wider open enrollment period, or at the same time something happens in your life, you get married, you have a child, but you also found out in the process of being pregnant that you might have some other GYN issues that need to be addressed, and you hadn't been insured before, you may take this opportunity to get insurance, and that pre-existing condition on an ACA or a qualified health plan is going to be covered. It would not be covered on a short-term limited duration plan. It would not be covered on a health sharing type plan because, again, both of those are going to impose pre-existing condition limitations. Plans kind of like the health sharing ministries are going to actually look back much further, some of them your entire life, to impose a pre-X on it. It's really a little dangerous and a little scary. But there is a role for short-term limited duration plans, but it should not necessarily be renewed year to year. And it max right now is 18 months. The other thing to remember with the short-term limited duration plans is that if you are able to and choose to renew that product, everything resets. So all your cost sharing resets. So although you may have contributed $1,000 towards your deductible, it goes to zero when that policy renews. So you're going to have to respend that again. So oftentimes you've paid a lot of money with zero coverage from the insurer. For pre-existing conditions, physicians might, or other medical professionals might use a different definition than what an insurer does. So you're going to want to look in the policy for how that's being defined. And in a couple slides, I'll be able to show you some of the things that what we'll be looking for. And they're all going to pull your medical records. So they're going to want to be sure that they're that things that they're paying for are appropriate. So they're going to be checking for a recurring or a pre-existing condition that has happened in your past. There's limitations for how far back they can go on comprehensive products, but that is what a pre-X is. Next slide. And we're going to move a little quickly through some of these because I think you've heard these yesterday as well. But grievances under Wisconsin law, you can complain about anything. They can complain about the age of the magazines in the doctor's office. They can complain about the stripes in a parking lot, or they can complain about the conduct of the physician. They can complain about the care that was received or something that was not paid. You have the ability to appeal adverse determinations. So that tends to be more in the medical claim, not so much the magazines. There's very strict timeframes in the state and in federal. Right now, Wisconsin's preempted for qualified health plans, but not for grandfather plans or non-ACA plans. Again, the note here that Shelley brought up yesterday is we're really not making the medical determinations here. That's the role of the independent review organization and the medical teams on the insurer and that your own provider. Oftentimes they're the ones that are helping you with these appeals. The next slide is a polling slide. So which of the following statements is true? Short-term plans are required to provide coverage for pre-existing conditions. Qualified health plans under the ACA are required to provide coverage for pre-existing conditions. OCI is able to make medical determinations regarding pre-existing conditions. Filing an action in court is the only way to resolve disputes regarding pre-existing conditions. Great. You did amazing. Yes, the true statement is that qualified health plans under the ACA are required to provide coverage for pre-existing conditions. Next slide. So the next few slides, we're going to move at a faster pace to keep on schedule for your break. But also there's some
Julie?
overlap. Yes.
I'm sorry. We want a quick loop back on two questions going
Sure.
back to effectuating coverage and then also taxes.
Oh, sure.
So we just wanted to make the point that you had said that premiums have to be paid by December 15th for January 1st ACA coverage. I think I want to clarify that, like, ideally people would pay their premiums in advance of the start date of their coverage, but the ACA, the marketplace materials are pretty clear that January 1st is acceptable, and then they actually have a window after that before their coverage would be retroactively canceled. So they have up until January 1st, and then kind of a 30 days of flexibility. And then if they don't pay within that window, their coverage would be canceled retroactively. And I put a resource up about that. Does that make sense?
Yeah, so technically they're in, if they haven't paid at the beginning so technically they'd be starting a grace window, and depending on the type of coverage, if they're getting assistance or not, is how long that period is going to be. So yes,
Okay.
they can pay as late as January 1, but that could cause some delays in processing of claims.
Yes, I agree. Or, I mean, not that I have to agree, but yes. Our second question is just about immigrants who might be getting coverage on the marketplace. Typically a very low income immigrant, maybe they're within that, they have legal status, they're within that 5 years where they wouldn't be a qualified immigrant for Medicaid programs. So they might be enrolling in a marketplace plan. And the question is, would a very low income immigrant who's getting marketplace coverage still have to file their taxes in order to, are they required to reconcile their taxes? And the answer to that is yes. So sort of regardless, if you have a marketplace plan, you need to do your taxes. Anything to add, Julie?
Nope.
Okay, let's continue on.
Okay, so the screen in front of you is medical necessity, and you hear this a lot in the adjudication of claims from health insurers. You're going to have to look inside the policies to find this because it is not defined by statute or rule. Each insurer is going to have a definition of it. Now, OCI does review those to make sure that they're not overly burdensome or so difficult to meet that it actually makes the coverage non-existent. So we are monitoring that, but it is not something that's defined. Examples of limitations that where you might see this is number of physical therapy sessions. They're looking to make sure that you're still making progress or that there's some medical benefit for it. We're not going to be able to know if 8 visits or 10 visits is correct, but the rationale that they're using is this term of medical necessity. Next slide. So again, this is coordinating if by chance you are in a family that has more than one coverage or an individual with more than one coverage, there are actually fairly complex rules as to who gets to pay first. And OCI's rules are a little bit antiquated and we are in the process of updating them, but it is still a sequence of which is the primary insurance company and which is the secondary. It is something that we walk through carefully with insurers, but they're actually pretty good on this. But we do get complaints on the sequencing when someone feels that, or they thought so-and-so's policy, their ex-spouse's was the primary when it actually was not. So those are issues that we do deal with and help resolve. Next slide. So network adequacy, you've heard us talk about networks. Sally did a nice job when we're talking about HMOs and PPOs. EPO is an exclusive provider organization, so it's incredibly narrow. But even though these things may be narrow, they still need to have adequate number of providers for the type of care that the consumers who are in their plans are going to need. So we are monitoring that they have sufficient provider contracts, regardless of the model of plan that they have. And if they, especially in these skinny plans, have they made it so skinny that they no longer have pediatrics or geriatrics or some major component of their of care that their consumers are going to need. So we do monitor their network adequacy to make sure that they have the sufficient number and type of providers to deliver the services they're saying they're going to provide by the terms of their policy. Next slide. And we're going to go, so I'm going to fly through this a little bit, but know that I'm going to go through this again in our next 2 hours. So don't get nervous if you're not catching it all. So the ACA has, all policies have deductibles, and the ACA has some limitations as to where those cost sharing maximums may be. And for a rule of thumb is that the family deductible would be no more than double the individual deductible rate on the ACA. The ACA, so that's governed by CMS and the Department of Health and Human Services, actually have different maximums than the IRS. So you're going to need to be sure for on-exchange products, it's a lot easier. When you're dealing generally with healthcare and people who may be receiving high deductible health plans, they have different limitations. In both cases, you need to look at the totality of the money in order to understand which product may be affordable for you. The next slide. So you're seeing both, you still see some of these terms once in a while, but a deductible is the amount that has to be paid before the company is going to begin paying its expenses. That is one component of cost sharing. An embedded deductible, or within the deductible, there may be a requirement for each individual to meet a dollar amount which cannot exceed for the ACA the individual's amount. So one individual can't pay the family deductible by just their claims, but each family member, before the insurer is going to pay first dollar, have to meet their individual deductibles. Then as a family, once that's reached, then all members get covered. On a non-embedded, if you had one member of your family that had a lot of illnesses or has more challenges, they used to be able to meet the entire family's deductible by just their costs. So that is something to look for in the policies. In 2016, the feds clarified in regulation that no individual can be required to pay more than the individual out-of-pocket max set by HHS for that year. So you're seeing these embedded deductibles on the ACA plans. Cost sharing, we'll go to this, and this is going to end up being a pretty good segue. I'm just sliding it, looking ahead quickly. A pretty good segue into our next sets of slides. But remember, when we're talking about cost sharing and affordability, is you have premium, which is the starting point, but then you have deductible, co-insurance, and co-payments, which are all out-of-pocket expenses that contribute to the overall cost of the product. So remember that the premium is just the starting point. When you're helping consumers, you need to then look at the rest of the costs and those, and we can just flip quickly to the next slide just as a starting point to end our time. This is called a summary of benefits and coverage, or an SBC. This is something that you're going to learn to love, and it gives a very high level, it's a required document, high level of what is involved and what the cost sharing limits are. Shannon, I'm going to actually stop on this deck here, given that we're just about at 10 o'clock for a break time. And I don't know if we have any more questions in queue at this time.
We have one question, and it is about immigration status and marketplace eligibility. So we'll just answer that quick and then we'll go to break. So the question was, in other words, does an immigrant have to have spent a minimum of 5 years in the United States to qualify for health insurance? And this is on the marketplace. And I'll just go ahead and give an answer. And the answer is no, they do not. So the 5-year limitation is associated with Medicare. No, I said that wrong. Medicaid and Badger Care. And so we see a lot of immigrants who maybe income-wise would qualify for Medicaid or Badger Care, but do not because of that 5-year hold on being eligible for those programs. And so we actively encourage those folks to go to the marketplace and get coverage and get the subsidies available. So just try to hold those two things in mind, that is a Medicaid rule, not a marketplace rule, and that the marketplace is actually a very appropriate place for those immigrants with legal status to get healthcare coverage. Anything to add, Julie?
No, I thought that was well said.
Okay, great.
And I know everyone's getting inundated with both Medicaid and insurance at the same time. So the confusion is very likely, but it is to keep those pockets separate is helpful.
Yeah, but that's a great question, because that's like something that navigators and certified application counselors are going to see time and time again. So to get clear on that and ask questions if you're not clear on that is very appropriate. So thanks for that question. So we will take a break now. We will return at 10:15. Julie, we'll finish up this slide deck and then go to the next one, or we're good.
I think I'll cover what was in the rest of this one into the other deck. So
Okay.
we had some overlap. So let's just start with the ACA Navigator deck.
Great. All right, so everyone, please take a moment to walk around, get some coffee, use the restroom. You can just leave your web browser open. If for some reason it gets closed, this morning's web link is on Covering Wisconsin's website or in your email. We'll see everyone back here at 10:15. Okay, welcome back. It is 10:15. It looks like Shelley is taking the reins, and we are going to return to hearing from the Office of the Commissioner of Insurance about the ACA and Navigator pre-licensing.
Okay. So again, we've gone over this slide a couple of times, so we'll just head on to the next slide, please. So just a high-level overview of the definition of a navigator. That is the person or individual that supervises or employs an individual who either performs any duties or activities related to the Navigator program on behalf of the Federal Exchange and who receives funding to perform such functions. An individual navigator does not include a person acting as an insurance intermediary. Next slide, please. A certified application counselor, who is known as a CAC, is a non-navigator assister who has been designated by or working on behalf of the Federal Exchange. Along with any federal training requirements, CACs are required to meet the training and examination requirements established for navigators, including the 16 hours of pre-licensing training and successful passage of the written examination. Once those requirements are met, CAC is not licensed by OCI, but a certification form must be submitted by the organization that CAC is working for. Next slide, please. So this is how, when you go to our website, the landing page for navigators and assisters are going to look. When you head over to the right-hand side, there are some plus symbols there. And when you click on those and open those, that's specifically going to give you each requirement that's needed for the entity that you're looking to become. It will provide you the requirements needed prior to taking the exam. It'll provide you the links for the study material for the examinations. It also provides you links to sign up for the examination itself and then the fingerprinting aspect of it after you pass. There are also frequently asked questions and obviously other very important, helpful information. This is going to be your go-to page for the information and procedures about becoming that licensed navigator or CAC. Next slide, please. So these are the straightforward 7 base requirements to become a navigator. This training, not only on our level, but also on the federal level, ensures a uniform base knowledge for those assisting customers. Next slide, please. And we're already to our first polling question. So which of the following is not a navigator licensing requirement? A, be fingerprinted and receive a background check. B, be appointed with an insurance company. C, be a resident of Wisconsin. Or D, be affiliated with a navigator entity. Very good. The answer is B, be appointed with an insurance company. Next slide, please. Agents that hold an active resident license with an accident and health line of authority and complete the Wisconsin and federal training requirements to become a navigator may be licensed as a navigator. However, an agent cannot have any active appointments with a health insurance company and cannot receive commission from that health insurance company. Agents must be certified by the Federal Exchange as a navigator and be affiliated with one of the entities that receive a Federal Navigator grant. Next slide, please. So here again are the initial requirements a navigator needs in order to become licensed here in the state of Wisconsin. As I give you a few moments to review these requirements, I remind you again that all of this information can be found on our website with links to sign up for the exam, the fingerprinting, and the electronic application as well. Next slide, please. Pretty straightforward renewal requirements. You must continue to obtain CE credits each year and also any federal mandated training, pay the renewal fee. However, if for some reason your license is revoked, you do have the opportunity to get it back by, obviously paying the fees and getting those credits and then submitting them to us. There is a slightly, obviously, increased fee to get it reinstated, but those can be done. Next slide, please. Individuals working in settings such as qualified health centers, hospitals, healthcare providers, social services agencies, and local health departments who do the following must be registered with OCI. Help consumers fill out electronic and paper applications to establish eligibility for the Federal Exchange and public assistance programs, and who help consumers enroll in coverage on the Federal Exchange. A CAC is asked to complete the same initial pre-licensing requirements as a navigator, including the 16 hours of pre-licensing training and the successful passage of the written exam. As previously stated, this is in addition to any federal training requirements. Entities employing one or more non-navigator assisters are required to provide the Commissioner's Office with a list of all CAC counselors that it employs, supervises, or are affiliated with once the individuals are authorized by the Federal Exchange to provide the assistance. Entities employing, supervising, or affiliating with CACs assume legal responsibility for the acts of those counselors. Next slide, please. Although similar base knowledge requirements as the navigators, CACs are held to a different standard than navigators, but still are expected to be neutral and informed in order to provide a consumer with the best possible experience in choosing their health care. Next slide, please. Here are some of the permitted practices a navigator and CAC are allowed. Okay, sorry about that. These permitted activities are conducting public education activities to raise awareness of QHPs available within the Federal Exchange, distribute fair and impartial information concerning enrollment in a QHP through the Federal Exchange and the availability of premium tax credits and cost-sharing reductions that may be available. Explain that consumers may purchase health plans through the Federal Exchange or off the exchange. They need to make consumers aware that plans are available in the outside market and that they may want to talk to a licensed health insurance agent about health insurance options. They can facilitate enrollment in a QHP through the Federal Exchange. Outline information that a consumer will need to have available when applying for coverage through the exchange, and providing that information that will allow the consumer to access the Federal Exchange either at their home or at a computer terminal provided by the navigator. They need to explain to the consumer the following information: their potential eligibility for public or governmental programs, how the federal health insurance premium tax credit and cost sharing reductions work and their risks for use, if any, the federal health insurance tax credit. Describe the features and benefits of health coverage in general terms, including cost-sharing mechanisms like deductibles, co-pays, and co-insurance, and how they could affect the consumer. Describe what a summary of benefits document is and where to locate that document and relevant cost-sharing provisions within information from the QHPs. Explain how to find information about provider networks. Describe to them the different metal tiers and how the benefits may change at different metal tiers based on the consumer's income. They need to provide information in a manner that is culturally and linguistically appropriate to the needs of the population being served by the federal exchange. And lastly, they need to provide a referral for an individual to an appropriate state or federal agency who has a grievance, complaint, or question regarding their health plan, coverage, or a determination under such plan or coverage. Next slide, please. Some of the prohibited practices. Navigators are to be neutral providers of information, a valued resource in a very complex field. Neutrality is the key. The hope is to guide or navigate health insurance terms, networks costs, and guide a consumer so that they can make an informed decision on health insurance, balancing their affordability and their tolerance of risk. Some prohibited activities are receiving compensation from an insurer, stop loss insurance, or a third-party administrator. Providing any information related to enrollment or other insurance products not offered on the federal exchange. Making or causing to be made false or misleading statements. Providing advice comparing health benefit plans that may be better or worse for the consumer or employer. Recommending a particular health benefit plan or insurer, or advising a consumer regarding a particular insurance or healthcare plan benefit selection. Lastly, engaging in any fraud, deceptive, or dishonest acts or unfair methods of competition. Any individual or entity acting in violation of the newly enacted laws provisions may be subject to administrative action, including restitution or limitation or revocation of a licensure or registration. The scope of cybersecurity law is fairly limited for entities that have already HIPAA compliant. Most licensees are exempt from the information security program provisions. All licensees need to comply with the post-breach notification requirements unless they are subject to HIPAA. Next slide, please. So on this screen, you're going to see a specific percentage of the Navigator exam, how it breaks down. This slide provides you with a line-by-line comparison of what sections the questions for the exam derive from. These are the areas of contents you need to focus on. There will not be questions on the exam, for example, about the history of health insurance, as that they are not relevant in your day-to-day doings. OCI expects all individuals who are guiding and assisting Wisconsin consumers on the complex matters of health insurance to understand this material and provide the best support possible to those they are helping, as that's what they would expect from you. All of these tools can be found in the Navigator guide on our website. Next slide, please. So again, this is just a summary of the information a candidate can find on our website surrounding the requirements needed and how to register for the exam. Next slide, please. So this is kind of a duplicate slide of what was talked about here earlier this morning by Julie. But again, the key notes on here is that the open enrollment timeframe for 2022 is November 1st through December 15th, 2021. And that also is the opportunity for you to assist a consumer who already has a marketplace plan to update any information. Again, maybe a change in marital status, a change in income, those types of things can be done during this time period too, to be effective Jan 1. Next slide, please. So again, slightly duplicate of this morning, but for what Julie talked about, but some of the examples, of changes that you can make during those SAPs are when you lose your job and or, reduction of hours, so you lose your benefits. A change in residence. So again, you move out of your zip code, out of your county, and again, possibly even out of the state, and or the birth, adoption, or marriage. So a change in your specific life. Next slide, please. So we're on to polling slide number 2. Special enrollment periods are available for individuals when they, A, are no longer eligible for Medicaid, B, receive a promotion at work, C, find an insurance plan that they like better, or D, want to change their primary care doctor.
Do
Oh,
you see the
awesome.
result, Shelley?
Yep,
Sorry.
they just popped up. Sorry about that. So great, everybody. The answer is A, when they are no longer eligible for Medicaid. Shannon, why don't you go ahead?
Yeah, okay. So we had a question about the exam, and it was just a question about is there ADA compliancy for taking the exam? And yes, all the exam centers are equipped to provide access in accordance with the American with Disabilities Act. So that is there. And then our next question was, I thought navigators could help people understand their plan regardless of them being available on the exchange. So I think this is going back to the limitations for navigators. And so I would invite any of the panelists to discuss this. Unmute yourself.
Yeah, this is Julie. Trying to get the camera on or not. Anyways, yeah, so there is a line that we're looking for. So navigators are not, obviously haven't gone through the same training as a licensed insurance agent. And so believe it or not, there's a lot more training than for the agents that they have to go through to do this. So what we're trying to do is the line of assisting versus giving insurance advice per se. So an insurance agent is licensed to be able to take it the next step further than to say, here are your options, but to delve in more deeply. And when this first started, we kind of said, and can push the button and actually enroll the consumer in these products. The Navigator line, I know in the prohibited acts and in an earlier slide, it was whether or not they could discuss that there may be products off exchange. So navigators are really tied to the federal exchange. That's where the funding is coming from. And so they really should be focusing on marketplace products. But the fact that there exists off market products is okay to say, but you can't go into those products per se. That's when you'd want to do a handoff to a licensed agent. Is that helpful, Shannon?
I think that's helpful. And I'll just also share that, like, as navigators and certified application counselors, it's important to kind of understand the situation and the environment, the health insurance environment in which the person before you presents. So to really be curious about what their past insurance is, what their options are, and then just to help them connect to the right insurance program or product. So it very well may be the marketplace, but in talking with the consumer, you might find out that they're eligible for coverage through their employer, through COBRA or something. And then you just want to make those appropriate warm handoffs to the right people. So as Julie was saying, if it ends up that as you interview this person and kind of really interrogate their insurance options, it might be appropriate to refer them to an agent or broker to buy an off marketplace plan, or maybe they have one and they just need to follow up with that agent or broker to really understand it or get more details, right? It also may be appropriate that you would refer them back to like their employer human resources department, because they really need to explore their COBRA options, because that might be the best health insurance option for them. So just to have a lot of curiosity and a lot of willingness to make those connections. Anything more you'd add to that, Julie?
No, I think that, the more you understand where they're coming from, the better you are going to be able to assist them.
Great. And then we have one other question, which is, can a navigator or a CAC become a licensed insurance agent being duly licensed?
Well, yes, navigators can become agents. They need to go through additional training. They have to do additional testing. And it is actually laid out in the statutes for how that transition can happen. The issue will be if they're wanting to continue as a navigator and they're going to seek expertise, let's say in health, so they're getting the health line of authority as an insurance agent, they can't have appointments with the companies or receive commissions because that removes your neutrality as a navigator. But there is a mechanism to bridge that. There's no prohibition for like a current licensed property and casualty agent to also become a navigator or an assister because their lines of authority or their appointments don't overlap with health. So it does go both ways, and there are mechanisms and recognition of these credits. So you've already done a fair number of credits, but I believe it's 30 credits for and 30 on a renewal basis, not your 8 for insurance agents. So that's definitely something to consider. And there is a lot of information on the OCI website for people interested in becoming a licensed insurance agent. The crossover where you become a navigator and an agent is where we're going to watch pretty carefully, because we do not want intended or unintended steerage to products where you may be able to gain financially through like commissions. We want to remove that and keep you as neutral as possible.
Great, thanks, Julie. Okay, Shelley, we can continue.
All righty. So again, a little bit of a repetitive slide from earlier this morning, but we do expect, as far as OCI does expect, the same number of insurers for 2022. The possibility of expansion of some of the service areas are things that we definitely have seen. So, and we know that there is at least 2 products being offered for every county at minimum. So again, there's that link on the slide to the interactive map that will be updated soon for 2022, but at least if you wanted to go explore it for now for 21, that would give you a pretty good idea how the map works. Next slide, please. Sorry. So there are some basic protections to back up the acts of agents and the engagement and ensure the engagement of insurers. The laws and regulations apply to all insurance policies delivered or issued for that, issued for delivery in the state. They include persons residing in Wisconsin where the group or policy certificate was issued, property or ordinarily located in Wisconsin, or business operations in Wisconsin. An insurance company has been notified if the company's authorized agent has been notified by or on behalf of the policyholder or insured and provided with sufficient information to identify the policy in question. There are some basic protections to back up the acts of agents and ensure the engagement of insurers. Every insurer is bound by an act of its agents performed in Wisconsin that is within its scope of the agent's authority. The company remains bound while the agency contract is in force or until the insurance company has made reasonable efforts to recover from the agent its policy forms and other documentation of the agency. Reasonable efforts shall include a formal demand in writing for the return of information and notice to the commissioner if the agent does not comply with the demand promptly. An insurance company is deemed to know any fact or material that violates a condition of the policy if the insurance company's agents who bound the policy, issued the policy, or transmitted the application to the insurer knew the facts at the time he or she acted, or if afterwards any of the company's agents learned of the fact during the course of dealing with the policyholder as an agent and knew that the fact pertained to the policy. Insurance coverage is issued on the basis of the applicant's representations. Representations are oral or written statements made by an applicant. Misrepresentation by an intermediary is the use of written or oral statements which incorrectly describe the terms or benefits of any of the policy. A material misrepresentation is an untrue statement made by an applicant that would influence a prudent insurer in determining whether to accept the risk or in fixing the amount of premium in the event of such happenings. In addition to the Health Information Wisconsin enacted rules that require insurance companies and agents to provide written notice of its privacy policies and practices. This rule describes the condition under which insurance companies and their agents may disclose non-public personal financial information. This rule also establishes requirements for privacy notices. Insurers are required to notify the insureds of their right to file a complaint with the Office of the Commissioner of Insurance regarding problems they may have with their insurance. This notice is required for each policy or certificate issued by the insurer. Next slide, please. So we did touch on these a little bit yesterday. Again, proof of loss is to be furnished by the insurer as soon as reasonably possible and within 1 year after it was required of the policy. Unless otherwise provided by Wisconsin law subject to interest payment, an insurer must promptly pay most insurance claims within 30 days, as Julie previously mentioned here this morning. In most circumstances, unless otherwise provided, general law applies to mistakes in insurance contracts. Such a mistake does not constitute an offense for the insurance company unless the mistake was due to misrepresentation or concealment by the owner of the property. Any of the following done without just cause and such regulatory as to indicate to a general business practice constitute unfair claims methods and practices. Failure to promptly acknowledge pertinent communication with respect to claims arising under insurance policies. Failure to promptly provide the necessary claims forms, instructions, and reasonable assistance to insureds and claimants. Failure to attempt in good faith to effectuate fair and equitable settlements of claims in which liability has become reasonably clear, and knowingly misrepresenting to claimants pertinent facts or policy provisions. Each line of insurance has a time period for which a consumer has the right to return a policy without any penalty. For health insurance, a policyholder has the right within 10 days to return after receiving it. If the policyholder returns the policy within that 10-day period, the insurance contract is invalid and all payments made under the contract must be refunded. The right to return must be printed on or attached to the first page of each policy. Although, an insurer may cancel a policy for non-payment of premiums, the consumer is entitled to a grace period for that payment to be due. For health insurance policies, it is not less than 7 days for a weekly premium policy, not less than 10 days for a monthly premium policy, and not less than 31 days for all other policies. A consumer should always check their policy to see if an insurer includes that grace policy provision. And lastly, if you disagree with an insurer's determination, you do have the right to appeal through grievance processes. A company has their own internal grievance process procedures that would be followed. And if there is the possibility of an independent review after a determination has been made, that is through an independent organization that has absolutely no affiliation with the consumer or the insurer. However, whatever that independent review organization representative determines, the people involved with it are held by that determination. So we've come to the next slide, which is the break. but I don't think we're going to break here since we're doing pretty good time-wise. So I'm going to turn it back over to Julie.
So hi, so we're going to move, thank you for moving ahead on the slides.
Julie, can we pause and just do 2 questions?
Yeah, and then I also want to link some information from Shelley's slides before I go into this one as well. So this is a great time.
Excellent. All right, so our first question is, are agents and brokers required to be neutral?
No, they can definitely steer. They're going to have different commissions from their companies on commissions. They do have to represent the information fairly, and they do need to give accurate information. They cannot mislead through inaccurate information or the omission of information. So by omitting a critical piece of information, that is also a violation of Wisconsin law.
Julie, if you can you speak up and answer that question again? Some people were having trouble.
Sorry, yes, is that better?
That is better, thank you.
Sorry. Yeah, so agents can be technically not neutral. They're being compensated by their companies that they're representing. The thing that they mostly have to be careful about, though, is they cannot steer so much to a certain insurer through misleading, inaccurate, heavy-handedness, or information that includes omission of critical information. So they can't neglect to tell you that, oh, by the way, this is going to be, there is a pre-X on this product, or I'm not really selling you an ACA product, I'm going to sell you 5 different products and get better commissions, right? So we're watching the behavior of these agents to make sure that they're representing the products accurately. So are the insurers. I mean, they don't want misrepresentation of their products, but they can definitely, like, they may only sell for 2 companies. And in the area that the consumer resides, there may be other insurers who are present, but the agent isn't going to be able to talk about those other products because they're not appointed with them. So yes, there is some non-neutral benefits of being an insurance agent, which has pluses and minuses for the consumer.
And as navigators and CACs, if a navigator or CAC was to be talking with a consumer and they feel like the consumer got bad information from an agent or broker, what should they do?
So depending on what you are sensing, you can encourage the consumer, or you can file on the consumer's behalf a complaint with the Office of the Commissioner of Insurance. We will look at, what happened, what information was given. The highest frequency since the ACA has come around is misinformation. Consumers are Googling or searching for an ACA compliant plan, and both the feds and all states are monitoring this, but they may create a new product by pulling together like 3 or 4 different insurance pieces that they say then is comprehensive, but it really is not. And when you see someone's been misled, or you feel that they've been given inaccurate information to the point that it has caused some detriment to the consumer, let us know. Or if there's someone that is just widely spreading inaccurate information, let us know, especially if it's a licensee. And that includes our navigators. Remember, navigators are actually licensed with our office. So which leads a nice segue, unless there's another question, Shannon.
There's a really quick question, which is
Good.
just, after getting approved for a license, how long do you have it for, and are there renewals?
Yeah, so it's a navigator license is a 1-year license, and you have to do some continuing education, and then do your renewal application, which will require renewing again with the feds. You do not need to do the pre-licensing again or the examination, but you do need to show that you've done your continuing education.
Great, and that's it for questions. So we
Okay.
can proceed.
So some of the things that Shelley was on the 2 slides that she was just going through, that pertain to, that she talked a lot about what agents and insurers are looking at. Remember that navigators are also being held to being competent and trustworthy. So things like misrepresenting information or an unfair practice, um, misleading or providing inaccurate or through omission of information, uh, saying, speaking ill of certain companies, or, like, darn, if only you could be in this insurance company because they always pay claims without any questions for this type of service. Um, those are kinds of things that are not neutral. And really, in your role, you're facilitating consumers making the best educated decision that they can based on their personal sets of facts, their income, their family status, where they are located in our state, and what options they choose for what they want for health coverage. And again, where do they sit on that continuum of risk tolerance and financial ability to afford insurance. So what I'm going to do in this next half, and we will break still at 11, so I'll watch my slides for us. But I do want to go back through some of these pieces and tie them for you for why we're talking about this stuff now in the ACA Navigator slide deck. And it's because as assisters and navigators, these are still things you need to know. So I'm not going to beat heavily on this again. You've seen this slide, but it's really important. This is the continuum. This is where decisions get made for consumers on this health insurance. Where are you comfortable and what can you afford? What type of products are most appropriate? Are you never going to leave? There are people who won't leave their neighborhood, let alone their zip code. There are people who are more comfortable in their area code. And that may direct what type of products they may want. So if you really like to travel around and you have a great network of providers that you really want to see, you want to be sure that you're letting them know that if they pick this EPO cheap product, they're not going to see any of those providers, right? So in insurance and these contracts, you really need to be upfront with what these products are and what they aren't, because the unique aspects of a health insurance contract is you're also tying often the providers, not just what we are and aren't going to pay for, but also when are we going to pay? How are we going to pay? And that is where the deductibles and cost sharing come in. And we're going to do a deep dive with that coming up. So the next slide and the next two slides are going to go kind of together. They are our mandates, and Wisconsin actually has 23 mandated benefits, and we actually preceded these uh, as a leading state in consumer protections. So long before the ACA and HIPAA, many of these mandates date back to the mid 70s. Children who are disabled before the age of 18 can stay on their parents' insurance. There will be some proofs that need to go on, but they're eligible and it's mandated to have access to home health care and skilled nursing care. Kidney disease and transplant is a big issue, and we recently did a bulletin reminding insurers about this benefit. Coverage of newborns and adopted children. Remembering in the back of your head that this is health insurance is newer, so when these mandates were put in place, these were pretty novel concepts. Diabetic supplies and equipment is a big issue for a lot of consumers, especially with increasing price for some of those supplies. And one of the unique pieces with our mandate on equipment is insulin pumps. So they get a right to have a new one, at least one, no more than one a year. But if one's not working for you, you don't need to wait for the life of that warranty on that insulin pump before you may be eligible for a new one. That's pretty unique for Wisconsin. Maternity mammograms and drug treatments for HIV are pretty obvious, but are there. The next slide. So the next group of benefits, so these continue. So again, contraceptives in Wisconsin is for the to stop conception, not not nearly as broad as the federal mandate, and it is much more female-based than it is gender neutral. Dependents are up to age 26. For group products, there is mental health parity, and there is in the new in a different location in our statute is the expansion of that mental health and other substance abuse coverage that is in Wisconsin. TMJ is an old standby, but is still a mandated benefit, as is anesthesia for pediatric dental care. Autism, we were one of the leading states getting coverage for that. When students are away from home, there is still a requirement for some coverage for that student. The next slide, we kind of call these contingent benefits. And the reason I use that word is if the product for insurance offers coverage for this prescription or this treatment, then there shall be these pieces. So if they cover eye drops, prescription drugs, then they shall have the ability to refill the eye drops on a faster basis than a 30-day supply. Colorectal cancer screenings, again, if they're doing these screenings, they must cover this. You're seeing more of these, like with the oral and injected chemotherapy, since the passage of the ACA, because states that create new mandates after 2011 are going to have to pay the full costs of that new mandate. So instead of doing a brand new, thou shalt cover this, they're now doing these contingent. If you provide coverage here, then you shall also cover these additional pieces. The last four, the nurse practitioners and optometrists and chiropractors, if you cover this types of care that these providers give, then you can't discriminate against these types of providers. That's what those benefits are. And there was obviously COVID testing now is federally is FDA approved, and COVID testing is now one of those requirements. Now we had a sunset in Wisconsin for a limited time because we weren't sure when that was going to fall, but now that is part of the essential health benefits as a mandated benefit by the ACA, under the ACA through the feds. I think this is a good breaking point, Shannon. And if you can decide if you want to bring them back a minute or two early, or if we have some questions to fill a couple minutes.
Yeah, Julie, we do have a couple questions. I think we can fill 2 minutes and then we can break. So
Great.
We have one very relevant question, which is going back to the mandated benefits, and a question about the grandchildren. So can you just talk us through that?
So if you are a parent and you have a child who has a child, that grandchild can be added to your insurance until your child is 18, not 26. So the coverage for grandchildren is a subset that did not get expanded by the age 26 expansion for coverage of dependents. But as long as your child has a child, then you can add that grandchild onto your coverage until your child turns age 18.
And that would be like, you have a family policy, right? Your child is covered on it. Now your grandchild can also be covered on it. Is that correct?
Yeah,
Okay.
and or if during open enrollment, if you were on especially if you have a group plan at open enrollment, let's say your child had been on a different product, they have that opportunity to get added in as well as that grandchild.
So say you're on a plan and your child who's less than 18 has a child, does that give them a special enrollment window? Do you know?
My thought is yes.
Okay.
It's a change of life status and you're adding a dependent because the presumption that is built in that law is that the grandparents are caring for that, are helping at least in the care for that grandchild.
Great. Okay, and then the other question, which we'll do quick, is it's a little wordy, so I'll just read it slowly. If you were to be a CAC, so a certified application counselor, and an insurance agent and stay neutral, offering all insurance in the area, would you still get commissions? Or as a CAC, would you forego any commissions in a dual role?
Yeah, you would need to switch hats. Even for a CAC, you're going to need to get the neutrality hat on. The best examples that we heard about, even in like healthcare facilities, they may have some CACs. They have to switch hats. They can't be representing that hospital or an insurance that may be affiliated with that hospital. What we want the consumers to have is confidence in those who are assisting them in their neutrality, and not hear about or learn later that maybe they got steered into a product because of that relationship as an agent. There is some bright lines put out in the statutes, and I don't have them in front of me at the moment. I'll follow up if there's anything that I'd tweak on that answer. But you can hold those distinctions, but again, we would expect you not to be getting commissions and not following those appointments when you have that hat on. Now, you can have dual hats. So you can leave being your sister role and go back to your office and be an insurance agent, but you can't be an insurance agent while you're assisting and using the name as an assisting counselor.
Great.
That was a great
Thank
question.
you. Yeah. And then just, we have one more follow-up on the grandparent that I want to make sure we get to clarify, because this is a great question. So my grandchild can go on my insurance up until my grandchild's parent turns 26?
No, until your grandchild's parent turns 18. So it is not to 26. It did not get expanded when Wisconsin expanded coverage to age 26 prior to the ACA. But we did not, and it was a legislative intent to not expand the mandate for grandparents to that from 18 to 26. So for grandparent coverage, it is only till your child turns 18 who has the grandchild.
Excellent. Okay, we're going to wrap here for the break. We're 3 minutes late, but we're still going to return at 11:15 to get through our last hour of content. So thank you, Julie. Thank you, Shelley. Everybody, just leave your windows open, take a break, walk around, get some coffee, do what you need to do, and come back here at 11:15, please. Thanks.
Hope everyone is returning and having a good time. Had a good break. And we'll wait for Shannon for just a moment or two. There she comes.
Sorry.
There she is. Oh, no
The clock
problem.
in my kitchen is a little different than the clock at my desk, so my apologies. Thanks, Julie,
no
for
problem.
taking over. And go ahead and get started. We'll jump right in.
Yeah, so I want to link for you why we're going through some of these things that look more insurance agent and insurance company wise. Again, in the Navigator guide or the CAC guide that's on our OCI website, there are statutes in chapter 628, starting at approximately 628.92 through the end of that chapter. And then in the Insurance Administrative Code in INS chapter 6, starting at about 92 as well. But one of the pieces specifically is Wisconsin Statute 628.95 and INS Chapter 6.96, which go over prohibited practices for navigators and assisters. And so the slide that you see in front of you is similar to the concerns that we have for agents that we actually still have for assisters and navigators. So I wanted to make that connection for you. And where to find these practices. So in all things that are facing consumers, we're really hoping that communications are truthful and not misleading. And again, not misleading just by inaccurate words, but by omission of words. And there's no intent in Wisconsin statutes that you didn't intend to mislead them or you didn't intend to omit things. If you did and a decision was based on that, we're still going to be concerned about it. Disparaging remarks. Again, we're looking for you to be neutral. Unfair marketing practices. So this affects you as an assister or a navigator just as much as it does an insurance agent or a company. We don't want you to be saying, if you come to my place, I'll give you, $10, or if you refer someone, I'll give you some money if you buy this insurance product, right? We don't want you to discriminate. We don't want you to make misrepresentations or restrain competition. So if there are really 3 insurers or 10 insurers in the community that the consumer can choose from, you can't just show them one and say, this is done. That's all there is, because it's not. We want you to be truthful and upfront with this. You can't, now this is more of an agent issue, but you can't charge people money for assistance if you don't tell them that we're going to charge you for doing this. So this is more in an agent world. There are sometimes fees that have to be disclosed up front and agreed to up front. You can't use threats or other ways to make an undue influence. So if you say, back to my example earlier, that this is really the only company that's going to pay this type of claim, that's probably not accurate. But it also can give a fear or threat that if you go to a different insurer, that might not get covered. So you're using position or you're using facts inappropriately that may lead to a bad decision for the consumer. So we're really focused on this competency and trustworthiness, and being trustworthy is being upfront and fair and honest. So you're going to get hit right off the bat and pull on your memory for a polling question, which is our next slide. So the following are examples of unfair marketing practices. A, misrepresentation. B, unfair inducements. C, undue influence. D, all of the above.
And Julie, I'm not showing any active questions right now. So after the poll, we can just proceed.
Great, thank you.
All right, we're going to wrap up the poll.
Wonderful. I think we're at 100%. Great. The correct answer is all the above. All of those I just went through are examples of unfair marketing practices. So the next slide and the next couple slides, again, I'm going to link these back again to your role as an assister rather than just as an agent or a company. So just as we were talking about a few minutes ago, the sales and commissions and influence. So assisters and navigators are trying to be sure that the consumer understands what it is that they're purchasing. So is it an appropriate product? Is that a suitable sale? Or in your case, is it an appropriate product? So if someone is probably a high utilizer of healthcare services and does not have a lot of money, a bronze plan might not be a suitable product for them. Even though it has a low premium, it's going to have a high deductible, and it's not intended for a high utilization. It's kind of because there is an age tied to the bronze products. They're kind of, and catastrophic, they're kind of set up as a safety net. The catastrophic plans are for younger people who are probably tend to be healthier, but we're wanting them to get into the pool. You need to be upfront about so the question about being an agent and a sister, you can't get paid for doing your work through an agent as a result of your sale. So on this slide, what we're really looking for from you is that make sure you're getting that sufficient information to help present the right options that are available to them through the marketplace. The next slide is the same thing. Someone may come to you thinking they either have an ACA plan or they are in a stopgap situation. Remember what this product is and what it is not. So while it may be technically comprehensive, it is going to apply pre-existing condition limitation. It may also have other service limitations on it, like they won't cover maternity care unless you've been on the policy for 12 months. Those are acceptable on these short-term limited duration products, where it's clearly not going to be acceptable on an ACA plan. But it is a temporary gap. So if somebody comes when it's outside the open enrollment period and they don't have a triggering event that would give them an SEP, this is again where you're going to need a handoff to a licensed agent, but this may be an appropriate product for them. And the next slide, please. Again, you've heard these. These are not health sharing ministries. So I guess you're hearing our frustration with these products. It is really heartbreaking when we get complaints for people who thought they were buying insurance products. They either didn't hear or weren't told properly that these are not insurance. This is really solely on the consumer to pay these costs, and people are getting hit with hundreds of thousands of dollars in medical bills that they thought were going to be covered, but they're not. I mean, the whole premise is that you have to pay for this product and then hope out of the goodness, and that's why these are typically religious, hope that other people with shared beliefs are willing to help give you some money to offset those costs. It's really challenging in our position to see people who get financially harmed from some of these products who didn't understand what they were buying. The next slide. So as you all know, that the ACA was originally kind of set up and hoping that each state would take these rather than it being a federal based product. That really didn't happen. The costs for setting up a state exchange were incredibly prohibitive. And then just the challenge of getting it off the ground in as short of time as there was between the passage of the law and when the first policies were going to be open. There are state exchanges, and they are getting, a few states are reconsidering going into this right now. Our neighbor state, Minnesota, is a state-based exchange. So remember, on your border communities, be sure you know where the consumer lives. Maybe they work in Wisconsin but live in Minnesota. They're still going to be eligible in the Minnesota exchange, even though they may spend a lot of time in Wisconsin. And so you're going to need to be aware in your data collection of and your interview of your consumer where some of those lines are. You might hear the phrase of private exchange. That's not the same as the federal exchange. That is typically employers that set up for its employees and maybe combine some with other health benefits typically found in a self-funded employer's kind of situation. So if you hear a private exchange, that is not the ACA, that is not the federal exchange, that's not a state-based exchange. The next slide, please. So insurers that want to be on the exchange need to be qualified health plans. And to do that, they have to meet all the requirements of the ACA that are spelled out in federal law. They have to provide all these essential health benefits that Shelley went through earlier this morning. And they have to do that without, without cost sharing. So essential health benefits are first dollar coverage. So even if someone says that comes to you that they have an employer product that has what's called a high deductible health plan, essential health benefits can still get paid right away, even if you haven't met your deductible limits in those high deductible health plans. There's a carve out from the IRS on that so that people won't run afoul of that. There are established cost sharing limitations. Shelley went through the bronze, silver, gold, and platinum plans. There is also a catastrophic category, and they have to meet the requirements of the ACA. And if they choose to offer through the exchange, they also have to have that product off exchange. Again, Shelley brought up and went through some of these minimum essential coverage. Right now, this individual mandate requirement is set at a penalty of 0. The thought behind having a minimum essential coverage for everyone was trying to not, in insurance, you don't want to just gather the bad experience and group them. So it was trying to distribute that health experience across the entire population. If everyone had some level of coverage, from Medicaid or governmental products or individual products or group and products, there was going to be less steerage of the sickest people to the exchange products where there were benefits of like the advanced premium tax credits or cost sharing reductions. So the goal was to try to incentivize consumers to have minimum coverage. Currently, the penalty is set at 0. That law was not removed from the books. I don't foresee that coming back anytime soon, but that is what that mechanism is. So when you hear that, that's why that exists, is to try to control some steerage. The essential health benefits that were pointed out by Shelley this morning, I'm not going to reread them, but these are all benefits that need to be provided first dollar. So again, these are the 10 categories that are available. The one that's kind of unique for at least in Wisconsin, is both, we're used to rehabilitative services, which are getting you back a skill. Habilitative is a service that keeps or maintains or improves the functioning of a skill. And so insurers are able to define this habilitative service. And often a good example of a habilitative service may be the ongoing care in autism. That's a mandated benefit. But once you're past the acute phase and the intensive period of time for treatment, what you really want to do with that population is maintain skills. So that's a habilitative service versus a rehabilitative service. So now we're playing a little bit more deeper in the ACA. There are different types of assistance that come up under the ACA on exchange. The advanced premium tax credit. So this is based on income, and it is a calculator, which is why I mentioned if you have a client who made their best guess and said $20,000 was going to be their anticipated income for the coming year, and then changed jobs or got a raise or promotion, and now they're earning $40,000, they need to go back in and update their application and have that premium assistance modified. So that they don't have a true up at the end of the year where they're going to owe back to the government some of that tax credit that you received throughout the year. Consumers don't have to do that. They can say, I'm going to hold that for taxes, and although they can take this ahead, they're choosing not to, then they're going to get a refund built into their filing of their taxes on the backside. So instead of paying a reduced premium, they're going to pay the full premium and then receive a higher tax credit when they do their filing of their taxes. Cost sharing reduction is available and is coming back for those at the lowest levels of income who are no longer eligible for Medicaid, but are at a lower income level. And that is an important availability for these consumers. American Indians and Alaska Natives have more fluidity of coming in and out of the marketplace. So unlike unlike the general population who has SEPs only with life events or loss of a job, American Indians and Alaska Natives can actually monthly make determinations of whether or not they want to be on the exchange. So they have this ongoing rolling enrollment opportunities for those populations to be able to join the ACA. So again, that's going to we do have a large number of American Native populations in Wisconsin. I think there's either 14 or 17 tribe that are sovereign in our state, but who are might have both tribal members and non-tribal members and spouses that are bridging the ACA, maybe Medicaid, and maybe some other support systems, and trying to navigate through all of those pieces. And they have different rights, and we're still hoping that some of that gets fixed eventually with some of those gaps that happen for in this case, I'll use the word blended family for eligibility on the ACA. So I want to focus on one of the things that you're going to be doing is really walking people through how to select health insurance, right? And what we're going to do is kind of walk through that process, including going through the summary of benefits and coverage. This screen again gives you the healthcare.gov. Some of the biggest concerns that we see from in complaints is people were Googling healthcare and they went to healthcare.com or healthcare.net. And that is not the ACA federal marketplace. So it's going to be important that you get to the right links or double check with your clients that they're in the right place. As they're doing their application, they may be determined to be eligible for Medicaid. Then you're going to have those tools for referring your clients to receive benefits through the Department of Health Services to help sign those consumers up for Medicaid. They may be you may find that they're going to be eligible for some cost sharing reduction. The advanced premium tax credits are really built off of that silver level of product. So the second lowest silver cost plan where you live is what's going to set that APTC dollar amount, but that doesn't mean they have to stay on a silver product. They may want to, but they can use that same dollar amount against any other premiums for either bronze or gold or platinum. It will reduce if you do them, if you use it as an advanced tax credit rather than waiting, it will still reduce those premiums, but that's where it's fixed. And it's set based on that second lowest cost silver plan where you live. But you can only get those advanced premium tax credits if you are on the federal exchange or a state-based exchange. So the next slide, again, what you're looking for is you do need to make sure you're filing your taxes, following up with those questions again, because what they are doing is truing up what you projected your income and what they gave you as a result on premium tax credits with what you actually earned. Now, if your income actually went lower, that's also important, not just higher, but also lower. It's important to go and update your application. You may have become eligible for Medicaid and you have a whole plethora of benefits that could happen if you go and move to Medicaid. Or you can get more assistance and it may make your life a little bit easier, making all your other budget and monetary demands affordable. So it's important to keep those dollar amounts as accurate as possible. It's hard in December to know exactly what you may be earning a year from now, but that's why you can go into those applications and update that information. Let's go to the next slide. Thank you. So when you're talking with your consumers, this is really a contract that these people are entering. This is an agreement that you're going to pay your premium and they're going to provide coverage. So they're complex documents. I'm not going to say that they're not. They are hard to read. And one of the hardest things that we have as the insurance commissioner's office is really reinforcing that consumers need to read these documents. Read that policy when you get it. You get a window to say, no, this is not what I want. And you can return it. You can get your money back. If you do it during the open enrollment window, you can change your mind. You can see this policy and go, whoa, it doesn't have the network that I thought I was getting, or some change happened. Or a health condition arose and now you wanted a specialist. You can make those changes during that open enrollment period very fluidly, but be sure you read it. They need to identify the limitations and exclusions in these policies, how easy it is to get an out-of-network provider. Some policies may say, if we provide the service at all through one of our network providers, that's the only place we're going to cover it, and there's going to be zero coverage off that network. That's pretty frequent in HMOs, definitely in an EPO. You're going to get more breadth and more flexibility in a PPO or a preferred provider product, because there is going to be identified off-network benefits. When we get to the slide and we'll start walking through this cost sharing a little bit more, you'll see there's a cost for having that flexibility as well. On the next slide, so when I keep talking about affordability, it's really not just the premium. That's your starting point. When that has to be affordable, no question, right? But I don't want your clients to be so confident that they can afford that product and they choose to get a more expensive product if they're not remembering the other components of that they're going to be responsible with that product. And those are cost sharing. We loop them together as cost sharing as a phrase, but they include co-insurance, co-payments, and deductibles. And a co-insurance is, as the slide says, is a percentage of a cost. So you're not necessarily going to know what that number is when you're going in for a service, but you should know from your summary of benefits and coverage or from your policy what services are going to be subject to a co-insurance payment. A co-payment is typical flat fee, flat rate fee, like going to an office visit. So there's going to be a $15 copay every time you go to the pediatrician. Those often do not aggregate towards the out-of-pocket maximum. So you're going to want to read the document so you can give information fairly to the consumer about what their real expenses are going to be. And deductibles are going to be a fixed dollar amount that has to get paid. And remember, we talked a little bit about embedded and non-embedded. And the individual deductible versus a family deductible, but that's going to have to be met before the insurer starts paying, with the exception of the essential health benefits. Next slide. So diving a little bit more into these cost sharing, you need to, this is where having a really good conversation with the consumer you're assisting is really critical. So understanding not just, what their income is, but how much flexibility or how much movement is there in a month-to-month variation in their costs? Do they need something that is much more certain with less up and down, or can they handle a little bit more uncertainty in their finances? So that's going to affect what products are going to be best for them. Again, the more you pay in premium, usually those cost sharing components come down. So you have more predictability in that financial component of your insurance. So in here, you're going to look not just at when they're going to pay, but what is and what is not included in reaching that out-of-pocket max. So if you see that there's an out-of-pocket max, and the next screen is going to show you that is $2,000, but it doesn't include your co-pays, well, you need to have that family or the consumer think about how often do they go see a doctor. Because if they're seeing doctors frequently for ongoing routine care, and there's a $30 or a $40 co-payment for each time they go to the doctor, and it does not accumulate towards their out-of-pocket max, that really may affect the affordability of that product for them. So we're going to start walking through these. The other thing to be aware of is a prescription deductible may or may not be included in that deductible, and it is going to be identified in the summary of benefits and coverage. So sometimes there's a separate deductible and separate accumulator for your prescription drugs in addition to the medical deductibles. So again, this affects what's affordable for the family or the individual you're working with. So the next page is, and I think, yeah, Shannon has it nicely blown up for you, and I'm blowing the one up that I'm reading off of as well. So this is a required document for all ACA plans. You'll see this on and off. If they're considered a qualified health plan, they're going to have this product, this sheet, the summary, and this is page 1. There's a lot of information on this page. It's telling you which plan within the insurer this is about. So an insurer can have multiple different product designs. So they may have an EPO product, they may have an HMO product, they may have a PPO product. Okay, so it's the same insurer, but it's a different type of product. And they may have different levels of cost sharing. So they may not just, even within silver, they're meeting their percentage, but they may have 6 different options And you're going to need to look through these with your consumer to understand where the distinctions are. Healthcare.gov has a really nice feature of a compare plan. And I assist my nephew and my niece in getting their health insurance, and I have them go to that screen and they can see side by side some of these comparisons. But the product here is this is actually an example off of healthcare.gov, and it says that the overall deductible for this plan is $500 for an individual or $1,000 for a family. And it's saying that, typically you must pay the cost from the provider up to the amount of the deductible before the plan is going to start paying. And this one says that if you have family members on the plan, this one says each family member must meet their individual deductible until the total deductible expenses are paid by the family. So an individual who meets their deductible, this insurer is going to start paying for just that individual before they may pay for the rest of the family. Yes, there are preventive care services and primary care services that can be covered before you meet that deductible. That's what we were talking about with some of those essential health benefits. They're also saying on this screen that there's an out-of-pocket max. And this one must be a PPO because it has, for the network providers, if you use them, your deductible for an individual is $2,500, $5,000 for a family. But if you go to an out-of-network provider, you're going to be paying $4,000 deductible for an individual and $8,000 for a family before they're going to start paying. So there's a huge incentive for you to use the network providers, but there is still some coverage if these consumers want to go to a non-network provider. And that's a huge distinction for a consumer. In this one, the co-payments are telling you they are not going to accumulate towards your out-of-pocket maximum. So is the person you're working with a high user of office visits? The intent and the philosophy behind co-payments is that if you have to pay for some of your care, the belief is that you'll control your spending and help keep your costs down. I think reality more is if you put this co-payment so high, consumers tend not to use the services as early in a disease process as they should, and actually end up costing insurers and yourself more money, both in your health and your finances, by delaying care. So that co-payment is an important piece of this. And finally on the screen is, are there network providers and how do you get that list? So they have to actually give you a link and list the providers for you, so that if the consumer has, Dr. Smith, who they've seen their whole life and they want to be sure Dr. Smith's available, make sure you're checking this so that, and actually in healthcare.gov's tool, you get to insert Dr. Smith and they'll help narrow in their system products or plan options that have Dr. Smith within their network. So the next slide, please. So now we've kind of given you the big start. I'm going to break up the SBC a little bit by information. So again, what you're seeing is many insurers have networks, and what we saw on the slide ahead was that you're going to pay a lower out-of-pocket max if you're using their preferred providers, which means they've contracted to get discounts, right? An exclusive provider organization or an EPO, these skinny plans are coming, especially in highly urban areas or where there's really a one location shop in some rural locations. But you really need to be careful about that network and be respectful of those requirements and limitations. If a consumer, again, I won't leave my block kind of person, EPO may be the best option for them, and it may also be the most affordable for them. But if they like to pick and choose, or they like to, get some of their health services where other family members may be, that's probably not the best product for them. And that restriction you're going to need to be able to identify within their product plan design documents to help highlight that. It's not right or wrong, it's not good or bad, but it is something that a consumer needs to be aware of when they're making these decisions. On navigating the next slide, the covered items. So this is where being sure you both read your summary of benefits, but also the actual policy. What is and isn't covered has to be spelled out in the policy. But when you're buying the product, you don't always get to see the entire filing. And you can, when you are in healthcare.gov, there is a button to get to the insurer's website, but oftentimes you don't see everything or don't have time to maybe want to read everything. The next slide that's going to come up is the next slide that you're going to be familiar with. But things to look for is, are they some guarantees you get? If they're a QHP and they're on the federal exchange, they're going to be comprehensive. They're going to cover essential health benefits. They're going to cover those preventive care visits with no cost sharing. You're going to need to look for whether or not the prescription drugs are within the same out-of-pocket max or separate ones. So those are things you're going to need to look for. And here on your next slide, please, again, it's another snapshot from, this is a summary of benefit and coverage, and it goes through on your left side, what if you need this? So if you need immediate medical care, what services are available? You might need an emergency room, urgent care, medical transport. And now they're going to tell you if you use a network provider, because this one has, the same columns are always going to be here, but you're going to see if I had a EPO, there's going to be, instead of the 20 and 20 in the in-network, out-of-network, you're going to see 20% and 0 in the outer network, because they're not going to cover off network. Emergency is different. That wasn't a good example, but you need to look at both of these columns and see if there's what that cost is, because you'll see below in rehabilitative or habilitative services a doubling if you use an out-of-network provider. In the last column on this page are any limitations, exceptions, or important information. So if you look at the second line, there's a prior authorization requirement if you want to go, if you need to be admitted to a hospital. And for anesthesia, there's a 50% coinsurance. That's a pretty big thing to note in this product. And pregnancy. So again, cost sharing does not apply for preventive services. They're flagging that. Coinsurance may apply to your out-of-pocket max, okay? And there's some components of maternity care that are going to be base products and some that are not. So some tests and some radiographic tests may not be an essential health benefit and are going to have some costs. So they're laying out these coinsurance percentages. The difficulty with this screen, and I'll show you 2 screens from now, how they spell it out, is you don't necessarily know what that cost is that you're agreeing to pay 20% of. And this is that flexibility and unknowing of your financial, of your finances. Do you have the flexibility in a given month to take a hit? Or are you really at a point where you need to have less variability in your in unknown expenses coming up towards you? On the next slide, limitations and exclusions. So that last column on that SBC is critical to understand. They have to be spelled out, right? They need to tell you that's not a hide the ball on an insurance policy, but this is one area consumers tend to not look at until they're actually needing the service. So, oh, wait a second, is this surgery going to be covered at this hospital? Then they might go dig into their policy or they'll call their insurance company. But this is something that you'll want to identify for the consumer to be looking at. And you're going to initially be working off of that summary of benefits and coverage or that comparative tool in healthcare.gov. So limitations are contingent. They may or may not cover them, okay? That's why it's a limit, not an exclusion. An exclusion is flat out, we're not covering this. A frequent exclusion may be bariatric surgery. We're just not gonna cover it, okay? But knowing that and what your consumer's needs are may include or exclude a product for them. So maybe this isn't the best product for them if an exclusion is, I'm not going to come, knee surgery in a hospital setting rather than in an outpatient setting. That's an odd one, but it's made up anyways. Make sure that it works for your consumer. It helps avoid the surprise bills, okay? The next slide. So this one goes through your, so is kind of the expanded exclusions and limitations. Excluded services on that top box. Services your plan does not cover. Okay, it's not going to cover long-term care. It is not going to cover non-emergency care when you're traveling outside the US. It is not going to cover infertility treatment. Okay, now the next group are things that it may or may not cover. It may or may not cover acupuncture, but if there's a prescription, maybe it will, right? Hearing aids is a frequent one. It may or may not. Is there a medical basis? What happened? Why are you needing the hearing aid? They need more information. And use of chiropractic care, it has to be within the scope of their license. So a chiropractor treating a sore throat may or may not be covered, because that may or may not be within the scope of their license. Weight loss programs may or may not be covered depending on the consumer's biometrics. So this page also will outline that you have a right to appeal. You have a right to grieve and get assistance with that. It will also tell you if it's going to meet the minimum essential coverage. The next slide. So when you're trying to help a consumer decide, they have to look at the totality of this policy. They need to combine the base premium that may or may not be discounted with the advanced premium tax credit or some cost sharing reduction. They need to look at the total of that cost sharing. They need to consider the network. They need to consider what limitations and exclusions there may be when they say that this is the correct policy for them. That's a lot of decisions, which is why the summary of benefits and coverage is a really helpful tool for making these decisions. But having asked the good questions, doing that really good interview with your consumer is really important. And that will help make better decisions. Taking time to understand these is going to minimize the surprises. The next slide is kind of what the real cost is going to look like. So if you go to the next slide, Shannon, this is kind of a snapshot of what it would look like in real life if you selected this product. It is going to tell you, like, okay, these are set examples. So having a baby is a really good one. The plan is going to have a deductible of $500. Remember, the baby itself is going to start a new deductible for that individual once they're born. There's a specialty copayment of $50. There's a facility co-insurance that's going to be 20%. And other co-insurance for some other maybe labs or radiologic services are going to have a co-insurance. So what this page in this summary benefits and coverage does is actually lays out what the cost is going to be if you have this plan. The total example cost for them is that the cost for having this baby is $12,700. The components are that PEG would be responsible for paying is that $500 deductible, co-payments of $200 because there's multiple specialists that maybe this individual will be seeing. And there's going to be a co-insurance of $1,800. So although they have good coverage, PEG is still going to have out of pocket $2,560. Note right above that, there's a limit or exclusion. So something above, and it's spelled out that there may not be something that they received while they were there that's a covered benefit. So be careful that they see that. Diabetes is another good example, as is the fracture. Now, one thing to keep in mind, so this cost of this procedure is out of pocket $2,560 for PEG with this baby. That's not including all the premiums. So is this still affordable for this consumer? And this is where some unknowns with these co-insurances can really be difficult for consumers who have less flexibility in their finances. The next slide is a polling slide. Which of the following should be considered when selecting a health insurance plan? Premium, cost sharing, network and coverage, or all of the above? Phenomenal. Okay, I did my job. Yes, you need to consider all those pieces in order to make a good decision with selecting healthcare. The last slide, and I intentionally kind of moved through these quickly because I expected some questions to come. This is really kind of resources. Every policy, what we are looking for in policy forms, there's actually a checklist on the OCI website that all policies that are ACA comprehensive compliant are going to have to meet. So if you're wondering if they're going to have a certain type of coverage, you can check this checklist and see what we're expecting to see in the policies. We issue bulletins on health topics all the time, and we keep those updated on our website. If you go to our oci.wi.gov, just at our homepage, one of the options you can get is regulations. And in that tab is also our bulletins. Sometimes they're also in our news releases, what's new. We have lots of consumer publications specifically with health insurance on how to walk through different products, including Medicare. So Medicare is a complex situation, especially when you're getting close in age to being eligible for Medicare on an age basis only, and the interplay with the ACA. The Wisconsin produces this Wisconsin Insurance Report annually, and it gives you a snapshot of what we've done in the prior year. And it's a good indication of what's going on in the marketplace for health insurance. We have links to Wisconsin Covered, which was launched last year by Governor Evers in conjunction with OCI, DHS, and I believe Covering Wisconsin is part of that as well. Again, I can't stress enough, when you're prepping for your exam, go to our OCI pages. You can even just type in as a search. There's a search bar almost immediately when you get to our homepage. Type in Navigator, type in Certified Assister, and it's going to bring you to that page with a ton of drop downs. But do use it. It has our guide. If you study well and it's attend some of those office hours with Shannon that are coming, you should do just fine. But I intended to leave some time for questions because I know I flew through the summary benefits and coverage pretty quickly, or any other topics, feel free. So where are we on any questions, Shannon?
Okay, so we've got a few questions, and some of them go back to content that, you know, it's been a number of minutes since we looked at it. So
yeah.
The first question is, can a navigator enroll someone in a plan in another state on the federal exchange?
So a licensed navigator is going to be, you're going to need to be licensed in the state that you are working with. But if you're working, so your contract's really with the feds. So anywhere where the feds are, you can assist a consumer. That is one of the benefits of being a navigator. And that is your goal, is to help facilitate enrollments on the exchange. You may want to make sure that if there may or may not be additional requirements in the state that consumer is in for a navigator, like Wisconsin has this pre-licensing and a licensing requirement. Not all states may have the same thing. So if you're helping somebody in Iowa, be sure you know what Iowa's requirements are. But yes, you can assist them. You may not, there may be limitations that Iowa has, but just be aware of that.
So I will say, just to add to what Julia said, that if somebody calls from outside of Wisconsin, we encourage you to find the navigator entity in their state, or a navigator entity that is designated to serve more than one state, and do a warm handoff to a navigator there. So, you know, if they're outside of Wisconsin, there are tools on the exchange where you can help them find somebody who is local to them, and we encourage you to use those tools.
Yeah, there's just not a probate. I can't stop you from doing that. So Shannon and I are coming from two slightly different perspectives on that, and both are correct. And I wholeheartedly support Shannon's recommendation that you do a warm handoff. There are intricacies of each state's laws that are really important to know. And I would hope that you do that handoff rather than trying to do it globally. But I know from our systems here at OCI, we know that people are serving the healthcare.gov from multiple states.
So our next question is, if you go to an emergency room that is out of network and you are too ill to be transferred to an in-network hospital, will you still be charged the higher rate or the higher percentage?
That's a great question. Two different things come into play with that, especially starting in January. And depending on some states right now. Emergency care is emergency care. And we have on Wisconsin's laws in Chapter 632 that if you are having a prudent person would go to the emergency room, and we're not doing a retrospective on it, but before you walk in, if you think that's the right place for you, there is coverage, and it's to be done at the in-network sharing level, not the out-of-network sharing level. If you need continued care, you're hospitalized, they need to keep you until you're stable. The question will come once you're stable if you need to move facilities. And that's where you need to contact your insurance company. You should be telling them that you're being admitted because as you saw, many plans have prior authorization for admission. Most of that is happening actually if you're in a ER, the hospital's already reaching out to your insurance company and facilitating that coverage. But in Wisconsin, there's going to be an in-network sharing level. The next piece comes with balance billing or surprise billing. For emergencies in many states, they can't balance bill you. So I know in Missouri right now, if you had an emergency, they can't balance bill for what your network insurance plan didn't cover. In January, that's a surprise billing law that was passed by the feds. That will be in place as well here, that you can't be billed beyond that in-network level.
Great, thanks, Julie. We don't have any other questions right now, but let's give people just a minute or two. I know sometimes people are frantically typing and then I don't want to cut anyone off. And I was just wondering, do you have any insight given sort of the situation with hospital capacity and COVID-19 right now, even if people are stable but unable to be transferred, are there any special rules that address the emergency situation that many people in hospitals are facing?
Yeah, I mean, there was, and a sad story, but a gentleman tried 43 different hospital ICUs who was having cardiac issues, and there was no availability anywhere, and he did end up passing. But COVID in Wisconsin right now, there are limitations, especially in different parts of our state, and there has to be a hospital to receive you. So again, you'd be working with your insurance company. I promise you, the hospital patient relations department will be actively working on that, as would your insurance company. They can't leave you if you're needing emergent or you're needing supportive care and you are not stable. It's in nobody's best interest to transfer you. And so they're not going to do that until there's a bed. Now, this is where having family members, if possible, available to support you is really critical, that there's somebody asking those questions and making sure that those checks are being done. When you're stable, what is the expectation from your insurance company? And they're very good about getting on the phone with you to help figure that out in as much live time as possible. Many have reviewers that go into the hospitals and see where you're at and how you're progressing and whether or not you're fully stable to maybe move to an in-network facility. And that's the same for medical bases as it is for mental health. So people in mental health crises are just in an emergency, just like anyone else. And again, they're going to look for whether or not you're stable enough to be transported to a in-network facility. They will be negotiating with that hospital to control their costs, and they will be trying to keep you at an in-network rate to the extent that this was precipitated by an emergency, and try to minimize some of those costs. The balance billing issues are issues and will be lessened with the federal law, but right today it's a very complex situation that there are great resources within hospitals and within insurers that are willing to work with you to make it make sense and make it work for your financial and health to your best health outcome.
Great, thanks. We have two more questions. One is just someone desiring a little discussion about what happens if you didn't estimate your income correctly and you received those premium tax credits. What can happen depending on what your income range is?
Sure. So I'll do the top part, and Shannon, please feel free to jump in too. If you did either high or low, and let's go, you underestimated your income, and that gave you a greater amount of advanced premium tax credits. If at the end when you do your taxes, that disconnect is clear, they can actually make you repay those credits. So they're going to be it's going to be a charge on your taxes. So if you were going to get a refund of $1,000, you may only get $100 back. So they will recoup those monies at tax time, which is why I encourage you to tell your clients, anytime there's a change, please go in and update that information. You can do it as often as you like, and keep that as true as possible. It may or may not move your premium. It would take a good change in income before that happens. If you underreported, if you overreport your income and you are actually due more tax credit than you took, you will get a tax credit when you do your taxes. So if you thought you'd earn 40,000 and you only earned 30, but you didn't update during the year, you may be eligible for additional tax credit that would come when you file your taxes. Another really important reason to file your taxes. Shannon, do you have other thoughts?
Yeah, the only thing I'll add is that there are some repayment caps depending on your federal poverty level. But if you are above 400% of the FPL, if that's where you land at the end of the tax year, you are responsible for the entire subsidy. So getting income right with those folks who are at or near that level can be really vital, because they'll be responsible for the entire subsidy. Below 400%, there are some limitations to how much they'll have to pay back. They may not have to pay back the full amount, but they'll still be on the hook for some of it.
And Shannon, is that if they have a reduced, if they have a cap, is it cumulative over a couple of years, or will they just have a one-time cap on the recoupment?
It's each year. So
That's
there's
what
a
I thought.
cap.
Okay.
It's, it's less than 200%, and then there's 200 to 299. It's a certain amount, 300 to 399. And then if you're above 400, then you're responsible for the entire amount.
Right.
So just important to pay attention.
And it's a good habit to get into, to, like this year with the federal law that passed in March, it was really important to go back in and just update your page, even if your income didn't change, because the tax assistance did. So I'll use my nephew was able to actually save almost $150 a month in his premium by just going back into his account and updating that page because of the additional tax credits.
Okay, so we have one more question. I see we're at 12:13, so kind of perfect. If you are taken to an out-of-network hospital and you are unconscious and could not make the choice of where you are taken, would it be covered, and how would it be covered? So let's start with that. Then there's a little follow-up. So
okay, that's a great question. And that is going to be, if you're being transported either by a family member or otherwise, there's a presumption that it's an emergency and it's going to be at the in-network level. The risk is the balance billing.
Okay, and then the second part of that question is, then if you become stable enough to be moved but are still unconscious, who makes that decision if you have no one to make it for you?
So if you are do not have a document called like a durable power of attorney that appoints somebody to make that decision for you, typically there's going to be an advocate, a consumer advocate within the health facility that you are at that will coordinate with your insurance, because it's not in their best interest to expose you to financial risk. Again, the question is, if you are unconscious, how stable are you? If they feel you are stable and unconscious, and it is you have a network product, it is going to be in your best financial interest, and so likely you are going to be transported to an in-network facility. But again, that's going to be a medical decision.
Okay, getting a few more questions. Okay, so if we have a child who's on the parent's health insurance and they're under 26, if that child wanted to go on her own insurance during open enrollment, can she go on the marketplace, or does she have to stay on the parent's plan because it is offered to her?
I believe they can go on their own. If they just can't double up, is my understanding. You can get you can be on your parents'. So let's use a school age student. They can be on their parents' insurance, but let's say they go to school in Hawaii and you're in Wisconsin, they can get a student health insurance plan and have both products. I think they can. I think there's a question on the healthcare.gov of whether or not you are covered under another plan or an employer plan, which may pop you out of the federal exchange, but there may be other insurance options. Shannon, do you have thoughts on that?
I really wish I did, but I don't. I'm going to healthcare.gov to see what's there.
There's no requirement that you be on your parents' insurance. Okay, they can't, but the question is whether or not you have available coverage. And it may, if you don't live in the same state or the same community, if they have a HMO, you may never be able to get benefits. So why are you on that product? So they can't prohibit you, is my memory from going through all those screens and laws. Unlike an employer coverage, like if you're the individual, if you have access to employer coverage and it is affordable to you, you need to take that, not the ACA. But I don't think that is true for a dependent.
All right, if we have any more insight, we'll include it in our conference follow-up. I'm going to post this link to everybody.
And Shannon's been posting links throughout. I hope you're looking at those in the chat. They're really good, helpful links to look at and let you see more in more detail, like the SBCs, so you get familiar with those documents.
Yeah, okay, so we're at 12:17. So I first want to thank Julie and Shelley for their time today and their presentation. Thought it was some really great content. And I also want to thank all the participants, especially the ones who asked questions. That's incredibly helpful. I think one of the most helpful things is going through these clarifying questions and having that interaction. So to that end, if you have more questions, as Julie shared, please, on October 1st, we're having some more sessions that will be very interactive. So there'll be just a general open office hours, first thing 9 o'clock in the morning, and Adam will host that. And if you have questions that you want addressed during office hours, please share those with staff at Covering Wisconsin. You can go to Covering Wisconsin's homepage, and there is a contact us link, and you can send those questions in through that contact us link. Then also, if you're concerned about that Navigator exam and you want to join the study session, we'll be doing that at 10:30 on Friday, October 1st. So feel free to join us for that. There isn't a formal registration for either of those things, so I included the links to those two things in the chat. You can just save the link and log on at that day and time, and you'll be able to join. And then on your screens, you can see that The next day we'll be convening will be Monday, September 20th at 9 a.m. And that will be for the beginning of the regular conference. Today, we are concluding the pre-licensing specific sessions, but because you are required to have 16 hours of pre-licensing education from the state of Wisconsin, you need to join for the regular conference sessions as well. They'll be great. You'll learn a lot. You know, I know we've had an intense 3 mornings here, but I think you'll really enjoy the regular conference and learn a lot. So please make sure that you join those sessions. We will be monitoring attendance, and when the full conference concludes, we'll be sharing attendance information with the Office of the Commissioner of Insurance, and they will be issuing the pre-licensing certificates that will enable you to take the Navigator and CAC exam. You can sign up for an exam now. Just make sure that you schedule it about a week out from the conference so you have time to get your pre-licensing certificate. You will be required to show that in order to sit for the exam. Those are all the updates I have. Mike, is there anything that you wanted to share before we conclude today? Oh, we have
Nope, I think you got it covered pretty well, Shannon. Thank you so much.
Okay, wonderful. Well, I wish you all a lovely Wednesday and look forward to seeing your names and hearing your questions or reading your questions on Monday. So thanks again, Julie. Thanks, Shelley. Thanks, Mike, for being our technical host. Enjoy the rest of your week.